Okay, Mike, we should be good to go.
All right. Thank you very much, Christine, for helping us organize things today and get this off. I'm very, very pleased that we can have this meeting today and have both Tom Morris and Michael Fallahkhair here from the Federal Office of Rural Health Policy. As you probably know, they were invited to visit with us in Bozeman back in September, and that just did not work out. Still too much pandemic around. So we very much appreciate them coming and today and filling us in kind of the latest from the Federal Office of Rural Health Policy, just the HRSA in general, and just kind of maybe the general feeling of what's going on within the workforce nationwide. Obviously, for FORHP, for those of you who are newer to 3RNet, has been a major supporter of our organization since the very beginning back in the mid 90s, and very much so a supporter to this date. Definitely with the leadership of Tom Morris, we really appreciate the partnership and all the great work that he has done and helped us with over the years. So Tom, I think you're going to go first, and then we'll turn it over to Michael after that. And again, appreciate the opportunity to welcome you here. And thanks again for joining us.
You bet. I think Michael's going to start, and then we're going to kick it back and forth. So Michael.
Yeah, and thank you, everyone. Sorry, hopefully there isn't too much feedback on my line. Great. So I just want to say hi, everyone. My name is Michael Fallahkhair, the Principal Advisor for Impact and Planning of the Federal Office of Rural Health Policy. With me, I have Tom Morse, as Mike just said, our Associate Administrator. Next slide, please. So today we're just going to do a quick overview of what HRSA and FORHP are for the folks who don't already know about FORHP. We're going to walk through the evolution of FORHP's workforce programs. We're going to talk a little bit about Medicare GME provisions, HRSA's program supporting the workforce, what's next. So there's some big key items that we really want to share with you all. The new ARP, so American Rescue Plan funding, some additional resources, and then just a discussion about the COVID programs that we have and the resources associated with that. So next slide, please.
Okay, well, Michael, thank you for setting that context. And so I just would say that, these are really busy times, obviously, and for all of us, I'm sure just as much for you all as it is for us. And within all of that, COVID is definitely front and center. And yet we're doing that while we're also doing our day jobs. And so you kind of try to keep that balance between the regular work that has to be done, but then also realizing that in a global pandemic, you got to do a lot of other things also. And it makes all of our work a little bit different, sometimes in little ways and sometimes in more dramatic ways. Certainly at HHS, it's been the overwhelming focus. And so, certainly in our interactions with the folks who work down in the main headquarters building, but also at the agency level, at the Health Resources and Services Administration, we've all been really busy trying to respond to the pandemic best we can, while also, keeping the programs and the policy machine operating. And this has primarily been through the sort of the execution of the president's executive order on COVID, which was a very aggressive effort to try to get a handle on the pandemic. But then subsequently, the passage of the American Rescue Plan and all the resources that have come along with that have sort of added to that. And so at HRSA, that's affected just about every part of the agency, because all of us have gotten funding and or either from the ARP or the prior bills that passed to work on COVID-related responses. That's certainly been true for all the health centers through the Bureau of Primary Health Care, but we've also seen a significant amount of resources come through the Maternal and Child Health Bureau for home visiting, and then also with our Bureau of Health Workforce. And our colleagues in BHW are going to get a lot busier here pretty soon, because they've just gotten approval to move forward on a number of the public health workforce programs that are coming out of the American Rescue Plan. And Michael will talk a little bit later about some funding we have in that, where we think there may be some opportunities for 3RNet members to really become a key part of the network for trying to fund. On top of that, we're also still, as an agency, administering the Provider Relief Fund, which has been, the budget for that is bigger than the entire agency, which is saying something. And those dollars have been a real lifeline for rural hospitals and clinics and other providers who have either seen, higher than expected expenses, or have lost, revenue because they haven't been able to provide their regular services. And Rural providers have been a big part of that, and we've been lucky to have a good working relationship with our provider relief colleagues. And so Sarah Young, who you may know from our office, who's a deputy director in our policy research division, has been really heavily involved in helping to sort of design the formulas. And so they recently announced the rural allocation, and she had a big hand in that. And at the same time, still answering questions and working people through the process of reporting from the first allocation of the Provider Relief Fund, a lot of which ended up going to rural providers. So as we think about, the work of the Federal Office of Rural Policy and the broader work that COVID is sort of demanding, we've just been happy to be able to play a limited role in trying to help rural providers, rural communities respond to the challenges the pandemic has brought. And that some of that has been pushing out new grant dollars, but it's also, doing something we never expected to be doing, and that was standing up a vaccination distribution program for rural health clinics. And I think we've got well over 160 rural health clinics right now who are ordering vaccines directly from our office on top of their state allocation. So, no doubt it's been a very busy time, both for the department, for the agency, and for our office. Next slide. And, this is probably redundant for a lot of you, but just a little reminder about who we are and what we do. Our charge in the Social Security Act is to advise the Secretary on rural issues. And we've been doing that since 1987. We sort of have a dual role in the sense that we have this department-wide charge to sort of be the voice for rural across all of HHS. But at the same time, we also administer a range of grant programs, both the state and local level, many of which are around capacity building. And so those all fit very well with the overall mission of HRSA, which very much focuses on underserved populations and disadvantaged groups and improving access to care in a variety of formats. And so, it's interesting. We're located in HRSA. It's a good fit for us, but at the same time, we have this broader charge, and that broader charge plays out in a number of different ways. A lot of times it's around workforce or working with our colleagues, either in the HRSA or other parts of HHS. And I'll talk a little bit about one of those interactions later because it does have some direct implications, I think, for the work you do. Next slide. For those of you who've been at this a while, workforce has had a pretty interesting evolution in our office because, it's an issue that preceded the creation of the office. It'll probably be an issue as long as there is a Federal Office of Rural Policy, because rural communities have always struggled to attract and retain doctors, nurses, dentists. You all know this better than anybody. And we're actually charged in our authorizing statute with focusing on rural workforce issues. And yet none of our programs until recently actually had the word workforce in them. Occasionally through some of our community-based funding, which is non-categorical, meaning that anybody can come in for whatever project they think will improve access to care. Occasionally we'd get some projects that focused on workforce, but not that often. And then we've done a couple of one-offs in that program and that authority. We did an allied health program a couple of years ago, and we did a health IT workforce training program a couple of years ago. But that's been sort of ad hoc, really. The one constant in terms of workforce for us has been the support of the Rural Recruitment and Retention Network. And so, I often, especially around every year around performance measurement time, I look across the metrics that I have to report on to show that we're doing what we're charged with doing. And the workforce metric that has always been the strongest for us has been the work that you all do at the state level. And so, you've made the office look good over the years because of all the folks that you've been able to place in rural communities, but also the work you've done with individual communities and providers to get providers to stay there, to help them fashion workforce strategies that really are enmeshed in that community in a way that ensures, that they understand that you never stop recruiting the providers that you come to your community. It's a constant sort of effort to keep them there. And so 3RNet has been that one constant across the history of the office. Then a couple of years ago, maybe about 5 or 6 years ago, we wanted to do more around rural training tracks. I mean, you all know that these rural training tracks that sort of were very much a grassroots creation going back many, many years. Were an effort to get training out of the academic health center and into rural communities. And I was always intrigued by these entities because it seemed like a good model and one that made sense for rural communities. And we also knew that based on a unique provision in the Medicare law, that even though there's a cap on the number of residencies, if you're starting a new program in rural communities, you can get Medicare support. So we gave a grant to the National Rural Health Association to look at rural training track technical assistance. And we had a fair amount of success in helping get a handful of programs off the ground and certainly raised awareness for it. And we conducted some research that showed that for a family medicine program at the rural training track, they were twice as likely to locate in a rural area after completion of their residency than if they had completed a normal family medicine residency program. And so it really is an evidence-based model, a model that works and works well. And we were happy to do that initial grant. But one of the big hurdles that we came across was the fact that many of the communities that we were working with, the biggest challenge was getting through the accreditation process. A lot of people wanted to open rural training tracks, but wanting to open one and actually getting through the accreditation process are two different things. And so in the course of that work, we started talking about those challenges, and somebody must have taken that to Capitol Hill, because ultimately they created the rural residency planning grants designed to specifically get at that. And that was the first time that we've had a formal workforce program in the Federal Office of Rural Policy, and it's been a nice companion to the work that we're able to provide some support to you all through 3RNet. So next slide. So I guess we've just funded our third cohort of rural residency planning grants, and the concept here was really born out from the lessons learned in that grant we had with NRHA, and that is, we know that you can start a new rural residency program under Medicare. We also know a number of state Medicaid programs are supporting residency programs. And so our thought was, and the deal we made with the House Appropriations Committee was, if you'll give us the funding to get them started, we will then hand them off to Medicare or Medicaid. And they liked that idea because they didn't feel like it was an open-ended commitment, and it relied on existing funding structures to keep those residencies going in perpetuity. And so, we had high hopes for this program, and they've all been exceeded. We've gotten some really interesting applications. We funded 46 grants so far. A handful of those grants are already accredited and have already begun training their residents. When we went in, we were thinking that we'd probably get mostly family medicine and internal medicine, yet we've had 4 psychiatry residency programs get started. And given, again, you all know this better than me, given the shortages of mental health providers in rural communities, the fact that we're starting to build rural psychiatry residency programs is a big, big plus. This year, we got our first general surgery application, so we're happy to see that. We all know what a need that is in rural communities. And so, this really couldn't have gone better than if we'd have thought about it. And, if you cast it in the larger light, I think that what we're seeing between our program and what you see with the Teaching Health Center program is this moving effort to get us out of the academic health center and show that you can do community-based training. And those folks are more likely to practice in the areas where we need them. And so it's not a cure-all for the maldistribution problem we have in rural communities, but it is one heck of a start, and one that we've been particularly happy of. And I mention this and go into this level of detail because I want to make sure you all are plugged into where those rural residencies are, and hopefully you are. And if you're not, what can we, let's talk about what we can do to make that happen, because these are going to be very small pipelines that are going to be producing physicians that hopefully you can then help communities recruit and retain to meet their physician needs moving forward. Next slide. And this got made a little bit easier by the fact that in the Consolidated Appropriations Act that just passed in December, they made some changes. Section 127 will expand the number of urban hospitals that can serve as that initial year of training for rural training tracks. So that greatly expands the universe of entities that can start rural training tracks now. And the Section 131, allows somebody to restart their what Medicare calls their GME cap. One of the problems that was identified was sometimes, a rural hospital might have a resident rotate through for a month or, 3 weeks or, whatever time. And they did it 10 years ago, and that started the clock on their Medicare GME cap. And so without even knowing it, they triggered that cap and were therefore no longer eligible to start a rural residency program. And I think everybody realized that was wrong. CMS felt it didn't have the authority to make that change. And so luckily the Congress came in and gave them the authority. And on top of that, Section 126 is going to allocate 200 residency slots a year for 5 years on top of already existing caps. And so there's language in there that creates 4 buckets, and one of those buckets is for rural. So we expect that a chunk of those 200 residency slots a year will be focused on providers in rural communities. We were lucky enough that we have a good relationship with CMS. They reached out to us early in the drafting of the proposed rule for this. And one of the things that we talked about with them was making sure that we look at it through a lens of health professional shortage areas. So if you follow that proposed rule, you'll see that the qualifying HPSA is one of the conditions that's been proposed. And so we'll be finalizing that rule fairly soon. And again, I think if you take this all together between this Section 126, between our ongoing work with the rural residency planning grants and also with the teaching health centers, in addition, Luis Padilla, who heads our Bureau of Health Workforce, also funded his first round of nurse practitioner residencies last year. And I think what we're seeing is, more of these sort of small pipelines that can be productive for years to come. And hopefully, you all are getting plugged into that and can then once these folks graduate from residency, they're there to be placed in rural communities. And the hope is that we can actually do that. So that's a little bit about where we are from a big picture perspective. I appreciate the opportunity to be with you today. I'm going to turn it over to Michael now, and just want to close by saying thank you for all the work that you do. And we really do value the partnership that we have with all of you and with 3RNet.
Thank you, Tom. Next slide, please. So I'm going to take it back a little bit back to the Federal Office of Rural Health Policy for the folks who, sorry if it's redundant for the folks who've heard this, but for the folks who haven't really figured out what we are yet, it's pretty easy, actually. All our divisions are synonymous with the work that we do. The one thing I do want to point out is that the Office for the Advancement of Telehealth is now pulled out of the Federal Office of Rural Health Policy, and it's been elevated to its own office level at the HRSA and HHS level. So what does that mean? That basically means that they are their own office. Although we are intertwined through some of our operational work, we share, of course, a lot of information. Much of telehealth's current activities are in rural. They have been provided the space to grow, given that how much telehealth has come out through the pandemic, the reduced regulatory barriers have come through. All of that to say that despite the fact that the telehealth office is no longer a part of the Federal Office of Rural Health Policy, it is still integral to the work that we're doing. We're still highly plugged into the work that they're doing, and they work with us on a daily basis. But as I said, the divisions in FORHP are pretty easy to figure out. The community-based division, the work is really focused on a range of community-based programs, with a bulk of that through the rural health outreach programs that we have. And you all may know one of the programs through there, the Rural Maternity and Obstetrics Management Strategies program. That's our RMOMS program, which is really focused on finding better ways to reduce maternal mortality in rural areas, but also find the sustainable financial reimbursement processes and set up so that we can ensure that women in high risk pregnancies and high risk situations can still get the care they need. It still helps to provide savings to the states, and we get a better system in place that we can ensure that there's a coordinated level of care. The Hospital State Division, you all probably work closely with some of their recipients. It's the State Offices of Rural Health. The Hospital State Division also supports a lot of quality improvement, performance improvement activities for rural critical access hospitals. Our Policy Research Division, just a set of all-stars. They're the ones who work closely with 3RNet, and we help really to set together the Rural Health Research Center programs, and really informs us, and as Tom said, informs CMS, the rest of HHS, and other policymakers more broadly on just what is going on in rural. How can we better impact rural through policy? And our last division listed on here is the Rural Strategic Initiatives Division. Really our range of special programming. Right now it's hosting about $165 million of rural opioid funding. It's a range of programs from planning to the implementation of opioid programs, neonatal abstinence syndrome, MAT, psychostimulant care. There's all sorts of opioid-related programs coming out of that office. So if in your world you're looking for more opioid questions, you're got a question about the data waivers or anything like that, please let us know. We'll be happy to connect you all to that. Next slide, please. So, I think the biggest takeaway from this slide, what I really want to take away is just how much there is in rural. I mean, if you look at it, there's over 4,000 RHCs. There's more than 4,000 rural critical health center or community health centers. And this map also shows us in pink all the 1,300 plus critical access hospitals. You all know this. You all can see like how much work there is for us to do in rural. But I really just wanted to sort of take a 20,000 foot or maybe like from space display just to see what's out there. Next slide, please. So in addition to the workforce programs that Tom just talked about, our partners in the Bureau of Health Workforce are leaders in providing opportunities for expanding healthcare workforce, and they've developed creative and innovative funding opportunities to support residency programs. So we all have heard about the Teaching Health Center and Planning Development Grant Program. That's really modeled after the rural residency program that Tom just talked about. It's a new program. It's geared towards developing primary care and dental residency programs and community-based ambulatory patient care settings. And this is both in rural and underserved areas. Another program that you'll hear about is the Preventative Medicine Residency Program, or PMR. It basically provides a total of 557 preventive medicine training slots through the next, I would say, has already happened, but will occur as well. And then the Advanced Nursing Education Nurse Practitioner Residency Program that supported the development or enhancement of nurse practitioner residency programs. So one thing we really want to take away is HRSA, even though it's a big agency, and HHS is even a larger department, we are all interconnected in ensuring that workforce opportunities exist for rural, that we are working on creative and innovative funding streams and opportunities for you all to look at and work on and ensure that the communities are getting the pipeline of providers you need. So if there's ever an idea, anything that comes to mind at your level, you're like, you know what, I've just not heard about this, or here's another thought that maybe we could better improve, please let us know. I'll provide the contact information later on the presentation, but we're always here to listen to any ideas that you all have. So sort of turning to like what's next, really just want to quickly just point out that the FORHP workforce work group and fostering, so we basically have work groups throughout our office. Our key ones in the past year that really have provided some really ingenuity are our health equity work group and our workforce work group. All of this is aimed at fostering greater cross-bureau collaboration. Bureaus are the larger entities within HRSA. If you take a step back for just our office, we can point to 4 new research studies that focus on workforce in rural areas. We've helped identify gaps in existing research, so such as specialty care, the surgery that Tom had just talked about. We're continuing to exist the FORHP program, so we can see that with the workforce group, we're better able to, participate in webinars, provide listening sessions to rural providers, figure out how to better leverage all our programs in an effort to ensure that there is the pipeline of workforce you all need, and really just to continue to amplify the rural voice of expanding rural health workforce in the larger national discussion. Next slide, please. Next slide after that. Yes, perfect. Thank you. So Tom alluded to this a little bit earlier, but we have some new funding from the American Rescue Plan solely focused on rural. Now, this is a game changer. As Tom said, there are not a lot of workforce-specific programs in rural. Now, the administration has really helped to make sure that there are $52 million available right now to train a range of healthcare workers to fill in-demand professions affected by COVID. You can see the list here, and I'll talk a little bit more about that in the next few slides. But one thing I just want you all to take away is that this is a really rare and unique opportunity. And we need to make sure that we take advantage of this opportunity. There are not many times that a rural specific workforce program comes out, especially with the level of broad flexibilities that this program will provide us. So we're currently in the development of the funding opportunity announcement. We expect it to come out in the next month, hopefully 6 weeks. And even if we provide 90 days to apply for it, that's still probably not going to be enough for everyone to apply. So if after this presentation you have any questions about this program, please let me know. But we highly encourage you all to reach out to communities around you who need workforce, and just to take a look at it and see what they can do, maybe that they can network or partner up with someone to apply for the program. So next slide, please. So the concept basically is pretty simple, but it's in the details where all the sort of complexities come. So it's about supporting networks linking educational entities, clinical sites, and key workforce stakeholders. We work to link directly back to potential workforce sites through practicums, employment, and ensure that the networks are community focused and use a shared co-equal governance approach. So there are 4 tracks. Community health workers is the key one for number 1, community paramedicine EMS for track 2, health information technology and telehealth support is track 3, respiratory support case management is track 4. Track 1 really is defined broadly for community health workers, navigators, oral health, promotoras, doulas, peer recovery support specialists. All of that factors into community health workers. The emphasis is very much on cross-training. So benefits counseling, coding, billing support, charting support, scribes, even patient service coordination fits into this, leaning into the social determinants of health and linking to non-clinical human or social services as well. That's sometimes a key thing that I think we sometimes lose in this is the social services aspect of this. And really the overall concept for track 1 is linking to functions that link directly to financial benefit to a clinical site and population health. Now, track 2 is community paramedicine. So it's leveraging EMSs and paramedics to focus on population health. Align all of that with value-based care by focusing on at-risk populations to avoid unnecessary ER visits or hospital readmissions. It's here to really assist patients in better managing chronic disease and help the community better screen out and do service referral. So overall, the concept for track 2, it's providing support to leverage existing training resources, support new and existing EMS staff with an interest in this model, and then expand the use of community paramedicine models throughout the rural communities. Now, track 3, it's really the telehealth and the health IT focused. I look at either expanding existing staff capacity or training or hiring staff to maintain use of telehealth systems. We know that these systems, there are a lot of complications to them. We recognize that there's stuff focused on at-home monitoring, so helping to educate staff on that, mHealth, other health record issues. And really the concept for track 3 is that smaller rural providers may lack the capacity to support of one or more full-time health IT support, but they may better be benefit by having a shared services, a shared sort of like a connection approach and model. So that instead of having one FTE, they share one FTE instead of one clinic having one FTE. Track 4, again, pretty easy, respiratory therapy and case management. This is where we try to bring in the connections to long-haul COVID and long-term COVID symptoms. Really, we try to expand training of respiratory therapists, given respiratory impact of patients with COVID, expand training of staff to assist with case management and coordination, given the high level of care and services for COVID. And really in the longer term, it's to develop the infrastructure that can be focused on a broader range of chronic disease management and support for respiratory diseases. Now, the concept for this is to develop and train those that we need to coordinate broader needs for patients with chronic disease, and to link them up with the patients that need services. So housing, food security, transportation, employment, all of this is factored under track 4. Next slide, please. So the expected timing, like I said, is in November. The review of the grant program would be in spring and the awards would be in the summer. The expected structure would be one single award and multi-year project period. So what that means is all the funding would come up front, and there would be multiple years after that. This will be an intense amount of funding. I can, without saying the exact number, I can tell you this is probably the most we provide to a rural grantee out of this office. So, it's a lot of money. It will require a lot of planning, but the time is being provided to let individuals work and plan out and implement their program. Now, like I said, I think our next steps are really engaging stakeholders like through our net to begin putting together network partners, focus areas, brainstorming governance. This is the thing that we recognize with rural applicants is that unless you've done this before, it's very hard to apply for a federal grant. You have to get all sorts of registration numbers. You got to have an employee identification number, tax ID number, all these basic things that everyone should have, but it's a lot more difficult unless you work in your finance office. Our real recommendation now is just please take the time to find and seek out the partners that can work on this. It may not be you, but it may be some other organization in your community who takes the lead on this application. You'll see that in the next slide. So next slide, please. So this is a range of the folks that we anticipate getting into this program. Really, the considerations for you all is that this is supposed to be developing community-focused networks and a governance model that ensures that we think regionally, ensures that training, placement, and employment provides identifiable benefits to rural clinical partners. We ensure that the training, placement, and employment aligns with value and links to population health, and that the focus on high-need communities is there to develop networks with a focus on diversity and health equity, which is going to be a key component of this funding opportunity as well. Next slide, please. So Tom alluded to this earlier as well, but thank you so much for the work that you all do through our net. Ever since 1995, we recognize that everything that through our net has done. I think in 2020, through our net facilitated over 2,000 job placements, which is incredible. We really do look to you all for your just the expertise and experience you bring and really helping to recruit as best as possible for rural communities. Next slide, please. And I talked about this a little bit earlier, but the Federal Office of Rural Health Policy currently funds rural health research centers and rural health policy analysis initiatives throughout the country. These are really the only federally funded research programs dedicated entirely to producing policy relevant research on healthcare and population in rural areas. This includes workforce. So we've had some pretty big programs and analysis come out, but I just wanted to point that out. The best way to get to that is the website link at the bottom. If you ever feel like your activities can be a part of the study, please let us know. Next slide, please. By now, hopefully everyone here knows about the Rural Health Information Hub, RHI Hub, but if you don't, this is an amazing website. It serves as a clearinghouse for all rural health activities. Topic guides are there, funding opportunities just like this one that we just talked about, models of innovation, so you'll find evidence-based practices, promising practice models on there for communities to sort of model after as they work on their applications. Next slide, please. Just wanted to quickly point out Rural Prep. If you all take some time, please take a look at this. It's funded by HRSA's Bureau of Health Workforce Academy Unit for Primary Care. It's really a focus on improving and sustaining rural health for community engagement. Many of you all are involved in PrEP or probably know about it, but I just want to acknowledge that and also credit the Bureau of Health Workforce for supporting it. Next slide, please. Lastly, I just want to talk about our COVID-19 activities. So you've heard about our rural health clinic programs. We've put $98 million in vaccine confidence to battle any vaccine hesitancy out there, really increase the equity that we have around vaccine. And we have our own vaccine distribution program that is from the federal allocation, not from the state or local allocation. So if you have a rural health clinic in your community or you're working with a rural health clinic in your community, they need vaccines, they can get it from us immediately. We can get it probably shipped down in 4 or 5 days. This includes boosters for kids, for anything. Please let us know. And at long term, really having a focus on the long haul COVID and the potential implications for the rural health workforce on that. So there's going to be more funding coming down the line for that aspect, but really just wanted to point out that we've already put out nearly $1 billion of COVID-19 funding. Next slide, please. If you're not already receiving our 4 weekly announcements, I would really highly recommend you do this. Please contact Michelle Daniels. Her email is circled right there. It's a great weekly announcement. Trust me, I have to read it like for 10 minutes every week to clear it. It's rural focused. It's got all our funding opportunities. It lists it from across government. We are able to include studies and activities from our partners like 3RNet on there. So it really provides a really valuable resource for anyone who has anything to do with rural health. Next slide, please. This is our contact information. If you have any information or questions or just comments, please let us know. And next slide, please. And please contact or connect with HRSA. Those are all our social media things. We don't like TikTok, but I'm sure we will at some point. So highly encourage you all to go in and just lastly, just wanted to thank you all for the work that you all do. Recognize that it is incredibly difficult. I know it's easy to joke about the pandemic and being like we're 19 or 20 months in. This is the normal. Like we don't have a new normal anymore. It's this. It kind of sucks sometimes. To be honest, I wish I was in person in Montana. It's a lot easier to just do a presentation like that. But that said, I really just want to point out that we're incredibly grateful for the work you all do. We highly value the information, the comments, the perspectives that you all bring to the table for us. It really does. Hopefully, a takeaway you have from this presentation is the work that 3RNet does, the voice that you all have for rural does actually have a major impact. We are able to create and implement new programs that really are able to increase the pipeline for years to come. So just wanted to thank everything that you all do, Mike and Christine as well. I mean, everyone really appreciate the work. With that's it.
Thank you so much, Michael. We really appreciate that. And thank you for all of the information. I think we have a few minutes till the top of the hour. Not that we need to keep folks, but I really would encourage our participants, feel free to unmute yourself if you'd like to ask a question or share a comment. I also will keep an eye on the chat if you would like to share something there as well.
Christine, this is Judd Mellinger-Blauk. Michael and Tom, thanks for your presentation. I'm the network coordinator, 3RNet's network coordinator for Pennsylvania. Wondering if you have any, two questions really, they're pretty much unrelated, but I'll ask them anyway. First of all, if you have any reflections on the recent national shortage designation update for HPSA scores. I don't know what other states encountered. Well, I kind of do know what other states encountered because I saw the national summary. In Pennsylvania, we took a dive. We took a dive with particularly our primary care scores and behavioral health scores. Any reflection on that? And then my second question, like I said, pretty much unrelated. Any talk about workforce, working on workforce issues for what I call frontline workers, paraprofessionals, folks like medical assistants, dental assistants, community health workers, and so forth, who are absolutely so critical to all care, for all health care, but particularly in rural and underserved areas. So I'll stop there and ask for your comments.
Sure, thank you. By the way, I just turned off my video because I got a note that said that my bandwidth is low, which I will just blame on our terrible government VPN that we have here, but hopefully everyone can hear me. So I'd say maybe to the second comment first, that's actually a really valuable point. We have raised these exact same points, and I don't know if Tom mentioned this earlier or not, but we actually just got, well, the Bureau of Health Workforce just got their spending plan approved by the Office of Management Budget for activities specifically for this. So you'll see more in the next, I'd say, 2 months, hopefully. But the reality is that this is a very critical aspect of not only just like, general nationally wise, but like rural wise. I can attest this, I have family who are doing these jobs and they are incredibly burned out. I think the level of resiliency, we throw that word around a lot, but honestly, I'm not quite sure how we're going to do this moving forward. But so, I do know that that means that we need to get a lot more people into the pipeline, and there's a lot of other confounding factors for that. But I will just say, without trying to give away too much and get ahead of them, because they literally just got it approved today, that's a key focus area. So the first question, I don't really have a thought on it because I'm not that as informed as I used to be on those scores and that but what I could do for you is you can always reach out to me and I can just make sure that someone here who works on that can hear your thoughts. And, if it doesn't have an immediate impact, trust me, there's a lot of value to having people like you and your experience, your expertise weighing in on things. Because sometimes program development, these kind of things can be weighted down by, I think, not necessarily complacency, but just hearing the same thing over and over again.
Right. That's great. We did share thoughts. And I always get mixed up whether it's BHW or BIPIC who oversees National Health Service Corps and the HPSA.
That's the Bureau of Health Workforce. Yeah.
Okay. I always get that mixed up. But they did have an RFI out last fall, I think. I mean, probably about a year ago. Actually, it was a year ago about changes, and they did not implement any of them in this latest one. But I think it's just too late. So hopefully they will implement some of that input from there. But I would be happy to reach out with a couple rural specific suggestions to you.
Please.
So thank you. Thank you.
Of course. Yeah.
Hey, Judd.
Annalie from Montana. Oh, sorry, Mike. I totally just cut you off. If I could just say, I kind of would like to bring up that fact again. Montana saw huge decreases, which are incredibly negatively impacting some of our sites to the point where we now have a site that is unable to recruit a needed OBGYN, and they're experiencing women having babies on the side of the road because there's no OB that they can get to in time. So I would love to join the effort to really highlight the negative impacts that states like Montana and other incredibly rural and frontier states are experiencing with these recent updates. It's pretty disheartening.
Sure, Annalie, you can definitely send me those comments as well. And I'll make sure that what I'll do is I'll work my best to make sure that you all are in touch with someone who can actually talk you through this from an actual informed position.
Yeah, where I was going to jump in here, sorry. Next week on Tuesday, we have BHW is going to be also doing a webinar for us. And that is going to be, I believe, Christine, correct me if I'm wrong, but I believe Melissa Ryan is going to be on.
Perfect.
Is that correct, Christine? Am I wrong about that?
Oh, no, that's correct.
What did I just do? Thank you.
Yeah, 2:00 Eastern. Yeah, thanks, Mike. That's
So
right.
that'll be our opportunity to hear from BHW about what's going on there, as well as Melissa, as you know, is pretty much, I think, the key person in this whole process when it comes to HPSAs. So anybody on the call for that next week, please come ready for, conversation there, because I know they're in a tough spot as well. But again, you guys are obviously in a tough spot. You're losing HPSA scores and losing. It's been very difficult. It's been a challenge. So feel free to join in for that next week when we have that opportunity to kind of talk to them face to face, and that'll be a good opportunity for us to share these comments and these actual events like you just experienced there in Montana. I appreciate the feedback, as disheartening as that is. It's important to hear. So thank you.
Yeah.
Okay, thanks, Mike.
Yeah, it's really good that you guys have that webinar set up.
I have a question, if that's okay, regarding the public health workforce grant.
Sure.
So hi, Michael. My name's Rachel Ruddick, and I'm the Workforce Development Manager for the Michigan State Office of Rural Health. So question surrounding this grant funding, in terms of thinking of a network or thinking of a region, if a particular region is already an R-Corps recipient or also an H-1B rural healthcare grant recipient through the Department of Labor, is it allowable to also be part of the network for the public health workforce grant, allowable to kind of maybe leverage those funds or braid those funds in some way, or at least be a network member? Would that be allowable?
Yeah, totally allowable. Totally. You could definitely be a network member. I would say for the funding aspect, this is how I would always frame any rural related funding, is that as long as an application is written in a way that identifies clearly the difference in projects between one source of funding and another source of funding, that's where everything comes kosher. If it looks like funding is for like one activity and you're sort of like double dipping through different funds, usually that won't be allowed. But yeah, totally allowable through network partners. And if you're able to work with the folks to make sure that they just show it's a different project or even slightly different, it doesn't have to be like, we're not asking someone to have one that's a substance use disorder program, another one to be uranium mining or something, but they can be along the same lines, just different.
Okay, wonderful, fantastic. And I wanted to just add a comment on the vaccine distribution program. My office is contracted through NOSOR to provide the technical assistance on that program. So for everyone on the call, if you have RHCs that need technical assistance on COVID vaccine distribution, they're actually going to be chatting and talking to me. So 3RNet members, so feel free to use the proper channels, but they will ultimately get to me for technical assistance on vaccine distribution. So just wanted to throw that out there. Thank
Rachel,
you.
thank you so much for your work on that. I know that is not easy because I was on many late night calls trying to get this program set up. So I have no doubt it's even harder trying to do the work.
It's a work in progress, but no one's done it before. So, just a lot to work out, but it's getting there. It's good.
That's what makes our jobs worth it, is doing something new, really changing things. So.
Yeah.
If there's no other calls or another questions, I had a quick one for you too, Michael. I was on the NOSOR meeting last week. They were talking about these, again, the rural public health workforce grants and kind of some listening sessions. Is there anything, first of all, scheduled that we can kind of formally participate in as those are being developed, or is there a way for us to kind of give some feedback to them? Because again, some of our members will be probably pretty involved with this, others may not be.
Yeah.
But what is there feedback you want us to basically want from us kind of more formally, or is there opportunities for meetings that we can participate in? Yeah,
that's a great question. So I know for a fact that like the community-based division team that's been hosting a lot of the webinars and getting a lot of this stuff, they've taken all the questions and comments and tried to put them into the funding opportunity announcement. I know this because I've seen their comments bubbles being like, someone asked this in a webinar, what do we do here? I will say this, I think we're already in the clearance process to get the funding opportunity announcement out. So it's probably a little late to get what I think would be like sort of game-changing comments if you're like, kind of change the direction of the program. But with that said, if you all, Mike, if you find out that there are comments or your members have comments where it's just about something here and there, please send it to me. I can't guarantee it'll get in the funding opportunity announcement, but I have to sign off, and Tom has to sign off before it leaves our office and gets released. So that's when we can probably add one or two things.
Okay.
Well, I think of course.
No, I appreciate the opportunity. And I said, I know we're anxiously kind of looking forward to seeing what comes out of those, both from, our organizational members as well as from 3RNet here, just to kind of see what opportunities may arise from that and what hopefully creative ideas people may have to address the 4 tracks there, because they're pretty well laid out, and probably not historically a lot of areas that we've been involved with, but it certainly doesn't mean we can't be. And I appreciate the opportunity.
Of course, I mean, for the folks that ran it, please realize a lot of this is from a lot of where we are with this program is because of what we hear from you all and what we hear from the SOARs. And, I just want to make clear that this is the reason why we really are, I think, unlike a lot of programs in FORHP's existence, we're really trying to really talk about this program a lot, is because we really want to show everyone, we really want to show the administration, the department, and Congress that this is a program that has a lot of need, that can really do quite a lot. And if there's success with this program, we anticipate that, of course, more funding will come. But we do know it's a major need, and we just really want to make sure that we get as many quality applicants as possible. And with that said, someone asked, how many workforce grants will there be per state? It's not going to be per state. I anticipate over 30 grants going out, maybe up to 50. I think that's really just at the last minute. It's going to be down to how much money we get set aside for this per grant award. And if any extra additional funding comes from the ARP. And someone asks, has there been surveys of rural hospitals and RHCs, and are there workforce needs or data? So yeah, we have had surveys put out for these kind of asks, and it's definitely sort of informed our development here. I don't think we've released anything publicly. I could be wrong, but I don't think we've released anything publicly around RHCs at least. So hopefully that helps, Kathy.
Michael, do you think most of those surveys have been done through the SOARs?
Yes, for sure. I mean, no doubt the RHC ones have been through the SOARs and through NARHC. The hospitals definitely through NOSOAR and the SOARs. And then some of the rural health research centers as well.
Okay.
Yeah.
I think Kathy asked again, do you have access to the data? Is that?
Can we get this info? I can check on that. I don't think so. And the reason why I say that is because it's probably linked to some internal system that we have here, but I can really take that one back and let me see what we can do here. And I see one more question here. Can states work together for these? Yes, they can work together for these grants. Regionally is defined broadly. So, if you find that you can coordinate resources across multiple states through the network, then yes, by all means, please apply.
And the other question I think was I heard Tom say maybe 4 to 6, or you said maybe, Michael, 4 to 6 weeks maybe for the grants?
4 to 6 weeks. I am hoping that it does not come out right before Thanksgiving, because people are going to be at home, hopefully enjoying time with their families and not thinking about this program, unlike us. But, the goal is to get it out by the end of November.
Okay.
Yeah.
And I'm pretty sure that'll be in the FORHP announcements, obviously, and other ways. So just.
Yes. Trust me. We are already working on the communication.
We'll forward everything we get from FORHP out there. So you should be seeing that. Just stay tuned.
Yes. Yeah. We will be doing a massive push for this. Yeah. Any other questions, folks?
Christine, do you see any on there? I haven't seen any others. So
No, I don't.
Okay. Had a good attendance today. Really appreciate everybody's time and joining us. And thanks, Tom. He had to go, but I do appreciate him kicking things off. Michael, thank you very much. Sorry we missed you in Bozeman.
Of course, yeah.
Hopefully we'll catch you sometime soon, maybe even next year. We're going to be in New Hampshire next year for our annual conference. Everything crossed. Hopefully that's where we'll be. And we'll see whether it's you or somebody else from your office. But certainly, we like having the latest from you every year, and appreciate you doing this in this format. I think it goes really well. And we'll be keeping our eye out for the funding opportunities and any other opportunities coming our way from you guys. So
thanks again. Thank you all. Really appreciate it.
Thanks for joining us, everybody. Really appreciate it. Thanks, Christine, Mark, and everybody for 3R Net side.
Yeah, thank you, Christine.
Together. Appreciate it.